Thank you, Professor Verma, for inviting me here, and thank you, Great Wall, ICC, and AHS for inviting me here for the management of hypertension in diabetes. So I shall be telling you about this management of the hypertension, specifically in the patients of the diabetes. The contents would be the story of hypertension in patient with diabetes, how can we monitor, what are the recommendations, and summary. So as we all know that it accounts for 10.8% of the total mortalities. Hypertension is one of the major public health issues, and out of which 4.6% of the disability adjusted life years are taken away by the hypertension only. Prevalence of hypertension is higher in patients with diabetes. It's a well-known fact. 50% of the hypertensions are also being diagnosed with type 2 diabetes, and its prevalence is increasing day by day. Because these two are the sibling diseases, most of the time I say, they are arising out of the common soil, and that common soil is the insulin resistance. Whenever we talk about the hypertension and diabetes, both are the end results of the metabolic syndrome. And if we look for their complications, complications are also the same, risk factors are also the same, but the hypertension is causing 3 times more on the health toll on the health, and expenditure increasing on the health as compared to the diabetes. When we talk about the diabetes, hypertension brings the arterial stiffness in the patients of the diabetes. It is more responsible for the nephroparenchymal causing the hypertension. On the other hand, the hypertension is getting microvascular damage because of the diabetes existing. In India, we very commonly see that sympathetic nervous system overactivity in patients of the hypertension, especially when they are associated with the diabetes. And many of the anti-hypertensive drugs are also responsible for hyperglycemia, like diuretics, beta blocker. So obesity, insulin resistance, when they are combined with the increased reactive oxygen species, higher level of the RAS activity, and combined with the sympathetic nervous system activity, which is very commonly seen in India, together with altered renal sodium handling, immune response, and raised inflammation, they all make it very complex cause-effect relationship between hypertension and diabetes that involves obesity, visceral adiposity, and insulin resistance as the main pathogenic factors. As we already said, and discussed that common risk factors among the diabetes and hypertension, common complications which are running through the atherosclerosis, endothelial dysfunction, vascular inflammation, fibrosis, and finally the arterial remodeling, ending up with the micro and macrovascular complications. But the management is not so difficult, just to bring down the level of blood pressure. Every 10 mm of mercury decrease in systolic blood pressure in hypertensive diabetic patient is associated with 12% reduction in complications pertaining to diabetes, 15% reduction in mortality due to diabetes-related complication, 13% reduction in microvascular complication, and 11% reduction in risk of MI. Good BP management in patients with diabetes significantly reduces the risk of cardiovascular complication, and sometimes it adds value to the hyperglycemia control even more than that. So how to monitor the patients of the diabetes, especially those who are having the hypertension? ABPM is recommended for the patient with diabetes and hypertension for reducing risk of post-treatment complications. Overall improvement of the blood pressure control is more needed because, as we have already heard by our previous speaker, Dr. Narsingh Verma, while he was talking about the blood pressure variability, we could know that blood pressure variability is one of the important features in patients with diabetes. Because of the sympathetic overdrive, because of the higher activity of the sympathetic nervous system, because of the changing schedule of our day-to-day activities, we are awakening late night and sleeping till late morning, then the hypertension has also changed its presentation. Many a times the midnight dip has been shifted from the midnight to the early morning. So this can only be caught by the ambulatory blood pressure monitoring. Very difficult to catch these kinds of a patient with the office blood pressure monitoring, very difficult by the home blood pressure monitoring also. But whenever we are doing these activities by the ambulatory blood pressure monitoring, calibration and validation of the BP measurement instrument must be considered. What does the ADA recommends for the BP measurements in diabetes patients. BP must be monitored at every office visit in patient with diabetes. In patient with elevated blood pressure, multiple reading must be taken for the diagnosis of hypertension. Now question arises, do we need to do out-of-office assessment in every patient with diabetes? Of course not. Those who are coming with stage 2 hypertension, 160 by 100 systolic and diastolic, they are not really needed to be confirmed by the out-of-office measurement of the blood pressure. They can taken up for the treatment, pharmacological and non-pharmacological, both kinds of the treatment together. But if your patient is having the blood pressure which is ranging between 140/90 to 160/100, then it needs to be confirmed by the out-of-office measurement that could be either ambulatory blood pressure monitoring or home blood pressure monitoring. The difference between clinical, home, ambulatory blood pressure monitoring has already been told by my previous speakers while telling about the Chinese guideline. That is the same in our Indian setup also. ABPM, what we see in the normal study, minimum 21 times in a day and 7 times in a night time is required, and percentage of the successful reading should be 70% or more. Systolic hypertension is 65% of the patients with diabetes is seen. The most important problem which is difficult to handle in patient with diabetes, that is a systolic hypertension. Most of the time we see that systolic hypertension 160, but the diastolic ranging around 670, even 65, 70, and that becomes a challenge for the person who is treating that diabetes. Isolated systolic hypertension is a challenge. Many a times it is above 80 years of the age, then we call it the age-related isolated systolic hypertension. Reactive hypertension, sometimes after the exercise, after the strained period or some activity which has happened in the daytime which is causing the raise in the blood pressure. Now the question arises, non-dippers. But the non-dippers is the biggest issue in the diabetic population. Usually we all know that 10 to 20% of the blood pressure falls in the night time as it is in the daytime. But those who have less than 10% of the dipping in the night time, they are called non-dippers. Those who have got the rise in blood pressure in night time, they are called the reverse dipper, and extreme dippers are those who are having the dipping more than 20%. This is the situation of the autonomic failure, what we usually seen in the case of the midnight. You can see that blood pressure is normal throughout the 24 hours, but in the night time, it is going up like anything. It is very commonly seen in Parkinson's disease. Now come over to the recommendations. In India, we are having the two popular recommendations for the management of hypertension in diabetes. One recommendation which has been issued by the Indian Society of Hypertension. Indian Society of Hypertension has recommended has released its guidelines last year in 2023 for all kinds of the hypertension, for all areas and fields of the hypertension. RSSDI has released its guidelines which are pertaining only for the hypertension in patients with diabetes. They are mentioning about the dietary and lifestyle recommendations, goal blood pressure, what should be the goal and where to start the therapy, what the pharmacotherapy should be preferred in the hypertension management in diabetes, and benefits of the individual drug classes. So if we talk about the dietary and lifestyle recommendation, it is recommended that office-based blood pressure monitoring, if it is found to be more than 140/90, we should start the pharmacological treatment with lifestyle modification together. But less than that, if the patient is ranging less than 140, then only the non-pharmacological methods are recommended to be started with. Systolic blood pressure target value should be kept between 120 to 130. Must be achieved in patient with coexisting diabetes and hypertension through combination of the dietary and lifestyle intervention. Nutrition education about the role of diet and knowledge of the healthy food choices must be given. Key dietary recommendation includes low sodium diet, which is very much focused and stressed in the Indian patient. Physical activity in form of the brisk walking session for 50 to 60 minutes, 3 to 4 times a week. We always focus and stress the low sodium diet in Indian population because Indian population is the sodium sensitive population. Now come over to the pharmacotherapeutic options and recommendations in diabetic hypertension. Individual profile of the patient and their response to the treatment must be evaluated for the selection of the most suitable treatment agent for hypertensive management. It's always recommended to start the treatment with the combination therapy. And most preferred combination in the patients of diabetes is the RAS blocker and calcium channel blocker. ARBs are the most preferred combined with the calcium channel blocker to be initiated in patient with hypertension for blood pressure control, reducing risk of complication and better patient adherence, having the grade B evidences. ARBs either alone or in combination with calcium channel blocker can be used in control of the blood pressure in diabetic patients having the grade A evidence. ARB must be preferred over the ACE inhibitors in diabetic patient with hypertension. Telmisartan or azilsartan being selected the first line agent, it's having the grade B recommendations. In patients at the risk of the cardiovascular disease, renal disorders or cerebrovascular disorders, combination therapy is preferred, having the grade B evidences. Calcium channel blocker must be preferred over the beta blockers and thiazides in combination therapy with RAS blockers, especially the ARBs. They are having the grade A evidence. The use of the beta blocker and thiazide diuretics must be avoided in patients with diabetes and hypertension because of their potential to cause cardiovascular events and hyperglycemia respectively, having the grade A evidences. Monitoring of the electrolyte levels, serum potassium, creatinine levels, as well as regular evaluation of the kidney function is recommended for patients with diabetic hypertension based on the choice of treatment agent and the risk profile. Now question arises, now we can see a flow chart which gives an idea and changing cascade of the treatment since from the 2014 to 2024. 2014 hypertension guidelines which have been released were saying to keep the goal blood pressure 140/90, may it be diabetes, may it be CKD, and initial treatments to be started with the RAS blocker or calcium channel blocker. Or you can, of course, use the thiazide type diuretics if you are going to start a treatment. In CKD patients, it was recommended to keep either ACE inhibitors or ARB, means limited to the RAS blockers. In ADA 2013, the recommendations for the diabetes has also changed to keep the goal blood pressure less than 140 systolic, but diastolic came down to 80. And RAS blockers were the preferred treatment to start with. European Society of Cardiology and ESH 2018 said that either it is CAD or it is CKD or it is diabetes, goal blood pressure is to be kept less than 140/90. And preferred treatment should start with RAS blocker combining with the calcium channel blocker or diuretic. Dual combinations have been preferred for the CAD. Similarly, the patient, those who were having CKD, they have been preferred again for the dual combination, but choices were remained almost the same. A RAS blocker, preferably ARB combining with the calcium channel blocker, or RAS blocker combining with the diuretic. Those who were diabetes again prefer to keep on the dual combination of the same choices. International Society of Hypertension released its guideline in 2020. They said CKD is having different, it should be kept less than 130/80 mm of mercury, but elderly have been given advantage to go little higher on the systolic blood pressure 140 mm of mercury. The initial management was recommended RAS blockers as first line. CCBs and diuretics could be added if needed in the elderly age group. KDIGO in 2012 said if CKD is not having any proteinuria, target should be 140/90. If it is having the proteinuria, then target should be less than 130/80. RAS blocker should be the preferred treatment. But in 2021, KDIGO same said that renal replacement therapy is needed to keep the blood pressure less than 130/80. If it is more than that, then you should try to bring it down using the calcium channel blockers or ARB. For patients with hypertension and diabetes, BP target must be kept close to 120 to 130 for reducing risk of the stroke. Now come over to the RAS blocker status in the patients with diabetic hypertension. Of course, they help in reducing the cardiovascular event, cerebrovascular event, renal complication. ARBs and ACE inhibitor most widely used antihypertensive drugs because of their similar effects on the CV outcome. ARBs help in reducing the cardiovascular and cerebrovascular risk and renal complication, therefore minimizing the morbidity and mortality risk in patients with hypertension. ARBs are safer, tolerant, more efficacious than ACE inhibitors for BP control. Risk towards the side effects is also lower with these agents compared with ACE inhibitors that induces the cough. Therapy having a combination of an ARB and an ACE inhibitor is not recommended as it is associated with an excess of adverse renal event. So ACE inhibitors may be preferred as a first-line treatment agent in patients with diabetic hypertension as an alternative to ARBs. Both these agents effectively reduce the risk of CVDs in high-risk patients, although ARBs are more efficacious. Both ARBs and ACE inhibitors effectively reduce the risk of end-stage renal disease. Now question arises, how to choose ARBs in patients with hypertension patients with type 2 diabetes? ARBs are administered in combination with other agents like calcium channel blockers or thiazide diuretics to reduce the risk of CVD and renal disorders in patients with diabetes. Telmisartan and losartans are the most effective choice for reduction in cardiovascular risk factors in diabetic patients. Telmisartan must be selected the first-line ARBs agent in diabetic patient because of its beneficial impacts on fasting blood glucose and insulin level. In those at higher risk of the stroke, losartan must be preferred, whereas the telmisartan is recommended in patients having a history of atrial fibrillation. Azilsartan improved the diastolic function of the left ventricle in patients with heart failure with preserved ejection fraction, also is a suitable agent for hypertension control in CKD patients. Now come over to the status of beta blockers in patients with diabetes hypertension. Patients, those who are already having a history of myocardial infarction, heart failure, coronary artery disease, stable angina, they should be and continue to be using beta blocker as an initial management of the hypertension in diabetic patient. But they should not be used as a primary treatment for the hypertension. They are being used a beta blocker for their existing cardiovascular disease. Beta blockers are not recommended independently, are only indicated as part of combination therapy with ARBs or ACE inhibitor in patients with diabetes. Safety of beta blockers in diabetic patient is questionable because they promote hypoglycemic state, increased risk of the cardiovascular events in patients with diabetes, and not recommended unless absolutely indicated. As far as the calcium channel blockers are concerned, widely used as first-line antihypertensive drug, exert potent antihypertensive action, more pronounced preventive effect on the stroke, significant reduction in the risk of coronary event, reduces the cardiovascular morbidity and mortality. Can be used alongside the ARBs as a part of combination therapy for management of hypertension in diabetic patients. As far as the novel calcium channel blockers are concerned, they are preferred due to their added pleiotropic benefits above their antihypertensive actions, but still we are waiting more data for them like cilnidipine and benidipine. Cilnidipine should be preferred over other CCBs in diabetic hypertensive because it has its effect on the tachycardia, it has effect on the serum uric acid level, it's having the greater tolerability, it has less pedal edema. So must be preferred in patients with proteinuria or pedal edema. It may be preferred over the existing calcium channel blocker. Once we talk about the diuretics in diabetic hypertension, we all know that all the diuretics are having some hyperglycemia potential. So it should be used selectively. They are not commonly used in management of hypertension in patients with diabetes. They are indicated in certain cases such as elderly patient with existing CVDs or the patient those who are having heart failure or risk of the heart failure. Use of diuretics such as hydrochlorothiazide is especially not recommended as a first-line management in patients with diabetic hypertension because of its potential to elevate fasting blood glucose and HbA1c level. Low-dose spironolactone is recommended in patients with serum potassium keeping less than 4.5, eGFR is maintaining more than 45, and thiazide-like diuretics like chlorthalidone demonstrated superior blood pressure reduction in patients with resistant hypertension. Now question arises, how to go ahead with the combination therapy and what is the impact of the potential combinations with efficacy results. ACE inhibitors, when they are combined with the diuretic, they are having stroke or TIA risk reduction 28%, 9% reduction in the micro and macrovascular events in diabetic patients, and hypertensive patients, those who are having more than 80 years of age, having the 34% cardiovascular events reduction. More than 70 years of the age, patient could see the 28% non-fatal stroke reduction. So we can see a sizable risk reduction, either it is CV events or stroke, or simply by using the dual drug therapy or combination therapy. Let's come over to the indication of the individual drug classes. So based on the guidelines, so there are multiple classes where we can say that some of the drugs are very good for the heart failure. Some of the drugs are the post-myocardial infarction are performing good, like beta blockers and ACE inhibitors and ARBs. High coronary disease risk, some of the drugs are performing good. Diabetes is having the preference for some other good number of the drugs. CKD and recurrent stroke prevention could be achieved by using the RAS blockers, diuretics, and calcium channel blockers. So this is the summary of the recommendation, where we can see that ARBs, ACE inhibitors are the two preferred RAS blockers where we can use as a first line combination therapy as one of the part of the combination. ARBs and ACE inhibitor should never be combined together. They should always be combined with the either calcium channel blocker or diuretics, as the case may be. So points to ponder: hypertension management mitigates vascular risk in diabetes. Therefore, BP should be checked every visit. Try to catch them early. We can start lifestyle modification even at times crosses 120/80. Office blood pressure monitoring could be enough to begin treatment if it is stage 2 or beyond. Loss of night dipping, nocturnal hypertension, mass hypertension is more common in diabetes. Therefore, ABPM or home blood pressure monitoring should be preferred. ABPM is current day's gold standard, although we look for some more evidence in our country to cut off for the 130/80 for both diagnosis and treatment, but in view of our population, we are more prone for the metabolic disorders, more prone for the diabetes, then it would be better to keep the blood pressure as low as possible, less than 130/80. But of course, in a diabetic patient, we do not recommend to go beyond 110 and 70. Thank you very much.